Everybody who's on the call today to our annual members meeting at DCHS. I'm Julie Holder and I'm the chair of DCHS, very privileged to be the chair, and I just want to go through a few housekeeping items if I could please. So could you please keep your microphones off unless you're speaking, because we get a lot of background noise. Feel free to have your cameras on or off, whatever is comfortable for you. For those that are speaking, can you remember not to try and cover your mouth? Sometimes it's a bit of a temptation to put your hands in the mouth. So if you could just remember that. We will be recording the meeting today, and that will be on YouTube, and there will be opportunities to ask questions, and there will be a live transcript as well. As you can see, we are today supported by 2 BSL interpreters, and you can click on their window or pin them at any time to make them larger on your screen for you to benefit from their involvement. And I just want to say, please don't be offended if we remove you from the meeting if you're unable to actually mute your microphone, to make it beneficial for everybody else on the call. So thank you. Why are we here today? So we're here today to provide a balanced view of our performance over the last 12 months, and that enables you as members to hold us to account. We're meeting virtually again because that allows us to be more accessible as we cover such a wide geography across Derby and Derbyshire. Our themes for the day follow our organisational strategy, and this was very important for us to do this because this is what we're delivering against to meet the challenges, but also maintain a focus on quality improvement for the services for our citizens within Derby and Derbyshire. Today, in the first section of the meeting, you will see us using the framework of those 4 strategic pillars: people at the centre, working in partnership, healthy communities, and a focus on the future. We've got some great speakers and some video content with great things to share with you under each of those themes, and I know that you're going to be very pleased with what you see and hear this afternoon. This is also Tracy Allen's final AMM with DCHS, and that makes it particularly poignant and emotional for all of us that know her, but I'll come back to that later on in the agenda. The executive team will take you through our key services, our people, our business, and over the last 12 months, and I'm going to invite some of our non-executive directors to just give a few words of their perspective of the last 12 months. We'll also hear from Lynn Welshaw as our lead governor, and our incoming chief executive, Jim Austin, will give us a look forward into the current year that we're actually in 24-25, and then we'll look forward to allow you to actually ask questions. But if you would just bear with me, because I just want to have a few moments for my reflections of the last 12 months. Last year was my first year as chair, and I gave a very brief reflection of my first few months. This year, I continue to be, excuse me, extremely proud of being the chair of DCHS. We are an amazing team, not perfect, always room for improvement. But what is absolutely fantastic is that all of us have the constant desire to learn and improve delivery of services, but also to support each other. Although we're presenting information about 23-24, at the time of this annual general meeting, we're facing a great deal of change. A change in government, changes in leadership within the system, change in leadership as we say goodbye to Tracy and to welcome Jim Austin. But as these few pictures demonstrate what's been important for me during the last 12 months, I want to sort of think of these again in line with the strategic priorities. Meeting people at our Time for Tea events has been wonderful. We've been able to acknowledge contributions, individual successes, and it never seems enough time to just hear about all of the hard work and the successes that we hear about, and of our teams who achieve and retain quality always gold. Being with our teams in various ways that we engage means that we meet a lot of staff and talk about the services they provide, some of their frustrations, what they're proud of, and what they want to achieve to support our communities. Just as important to me, though, in these meetings has been getting to know the person behind the lanyard, and I've had great privilege of having those discussions with people during my visits. The picture here is of the opening of the Community Diagnostic Centre at Whitworth, and it just goes to demonstrate, and this is just an example of what we can achieve in partnership. We heard at Whitworth about how we work together through the continued support of League of Friends, and how the project team pulled together people from across the system, and how our teams are now working together to deliver community diagnostic services. And finally, what a great picture of our leaders of the future. I've not spent as much time as I would have liked to be with our A to B cohort, but this is an excellent programme filled with enthusiasm and commitment. And many of us talk about being guardians of the current NHS, and this programme is about the role that we have to grow the guardians of the future. I'd also just like to reflect on some of the meetings that I get involved with. And in the next slide, you'll just see a few of these meetings that I personally get involved with, but our executive team and others within the organisation are involved in a plethora of other meetings on a day-to-day basis. The emphasis for me in the meetings that I've attended more recently has been to focus on not only delivering better performance now and experience today, but also looking to plan for the future, putting in place the strategies, the mechanisms, resources and ambition to deliver services and support our local communities closer to home, helping our population to help themselves and avoid admission into acute care. In short, what I want to say is, what has the last 12 months meant to me? Well, it's all about the people, listening, understanding, sharing and working together. Thank you very much. Before we get into the main part of our agenda now, I'd like to just take a moment with you to acknowledge and remember our colleagues who are no longer with us. Over the past year, we've lost valued members of our team who contributed greatly to this organisation. Their hard work, dedication and friendship have left a lasting impact on all of us. In their honour, I'd ask that we observe a moment of silence to reflect on their lives, their contributions and the memories we shared with them. Thank you. Okay, so we're going to get into our 4 strategic themes. And first of all, I'm going to invite Jane Ginniver to speak with you, people at the centre. Thanks, Jane.
Thanks, Julie. Good afternoon, everybody. I've been asked to present some of the headline data relating specifically to the inclusion and belonging part of the people at the centre pillar to our strategy. First of all, I thought it would be helpful to explain why this is particularly important to us. And ensuring that we've got staff who feel valued, welcomed and respected in work is critical not only for staff morale and engagement, but research also shows us that it has a direct impact on patient outcomes. This research tells us many things, and one of the key piece of data that I've pulled out of that is that colleagues who are treated, staff who are treated poorly by their colleagues perform 50% worse on cognitive tests. This has a direct impact on the quality of their work. And we need to ensure that all staff are able to give their best at work. Additionally, we need all of our patients, whatever their own personal circumstances, to truly know that our staff value and understand them. So next slide, please. The Workforce Race Equality Standard, which is known as the RES, and the Workforce Disability Equality Standard, known as the DES, contain a set of indicators that we have to report on and publish each year. Some of these are highlighted on this slide, and I'll talk briefly through them. The RES data for 2023-24 tells us that white candidates are 1.66 times more likely to be appointed from interview than minority ethnic candidates. We clearly have got a lot more work to do in this area, but it's worth noting that this indicator shows its 5th year of continued improvement. So we're definitely heading in the right direction and much closer to parity. So having an equal likelihood of being appointed than we were certainly 5 years ago. And like I say, it's been improvement every year since. As an aside, and it's not shown on this particular slide, on the DES data for this particular indicator, we do rank really well, with candidates with long-term conditions and disabilities as likely to be appointed as those without any disability. So that's really good news. On workforce representation, given the significant differences in population demographics between the city of Derby and Derbyshire County, it is difficult to gauge what representative would actually look like. However, we would like to see a greater proportion of our staff from ethnic minority communities, particularly as our data is lower than any of our system partners. This again, though, is an area where we've been continually improving year on year. And with respect to kind of the proportions of our staff who are from ethnic minority communities, we need to see people in more senior positions as well. Where we do have staff, they're primarily in the lower banded roles. So we need to see that start to change. And I'll come on to some of the stuff we're doing shortly. On our DES data, we compare really favourably around the numbers of our staff with long-term conditions who have a reasonable adjustments passport in place. A reasonable adjustments passport is a document which identifies the impact of health conditions on somebody's work and any support that can be put in place to enable staff to continue to make a full contribution. So having a kind of a high response rate, a positive response rate to this question indicates that we're doing significant amount of work to support all of those staff with disabilities and long-term conditions. We have done and we do continue to do a lot of work on reasonable adjustments passports. We've been actively promoting feedback and speaking up routes for staff. So it's encouraging to see that the number of staff with long-term conditions who would report incidents of bullying and harassment has increased by almost 8% in the past 2 years, up to 61%. Addressing harassment, bullying and abuse is a core area of focus for us as a trust. And we can see from the data that staff from ethnic minorities or staff with disabilities are more likely to experience such behaviours from patients and from other staff. Darren Tidmarsh will go into more detail later around the broader actions we're taking to reduce all bullying, harassment, abuse and discrimination. One of those core actions for the year ahead is to roll out active bystander training to provide staff with the skills and the confidence to support their colleagues when poor behaviours are experienced or witnessed, so that we're not just expecting staff who are experiencing those instances themselves to address it. They have the support of colleagues around them. Can you move on to the next slide, please? Thank you. Staff turnover is another way of us measuring our culture around inclusion. We know from this data that gay and lesbian staff and staff from some specific ethnic backgrounds are leaving DCHS at a greater rate than their counterparts. We're doing a broad piece of work linked in with the People Promise Exemplar programme to understand people's experiences better and to determine what actions we can take to change this. In terms of the stuff that we're working on now and over the coming year, Darren will talk more about the work that we're doing around the People Promise, so I'll not go into that, and I've already mentioned the Active Bystander programme. We do have an existing network of dignity and inclusion champions who we're working with now to develop their skills and confidence to make us more effective in getting key messages out across the trust as quickly as possible, and to support us all in embedding our inclusion and belonging ambitions. We've done a lot of work to improve the likelihood of staff reporting incidents. There are a lot of routes available for staff to report incidents in DCHS, which is great. And what we've been doing is focusing on clearer explanations to help staff to determine the best and most appropriate route for them. We're doing a lot of work around inclusive recruitment, which I touched on briefly earlier. For making changes to recruitment processes, they're the end-to-end recruitment processes from the actual application part, the application form that people have to fill in, the way that we do the applications, right the way through to selection and interview processes. And also developing training for those on interview panels. We're working quite a lot across the Derbyshire system as well around inclusive recruitment to make sure that we're getting really good systems and processes in place right the way across the Derbyshire health system. Hopefully, this will all support a further reduction in the RES score that I mentioned previously as well. And finally, we want to improve our data quality to enable us to have a fully accurate picture of staff experience across the trust. You can see on this slide that the numbers of people with not stated against some of their personal characteristics is quite high. And the lower this number is, the better a picture we will have of the success of our inclusion and belonging work. I'm going to stop speaking now, as I think the best way to hear about the culture that we have in place is to hear it directly from our staff. Two of our staff members, Harry Brown and Gurpreet Randhawa, talk about their personal experiences in this video.
At DCHS, the Staff Forum brings colleagues and executives together as equal partners to talk through topics and issues affecting staff. Meetings are aligned to the NHS People Promise and agendas are set by staff. The forum was relaunched at the beginning of 2024 with a focus very much on inclusion and belonging and ensuring everyone's voice can be heard via the Roundtable Forum membership. We draw on the knowledge of all members of the forum to come up with potential solutions to the issues that are being discussed. The Staff Forum is one of the ways in which DCHS is actively putting people at the centre. We are striving to get things right. We know there's plenty more to do. We spoke to two colleagues who have felt well supported by DCHS when they needed it.
Hi, I'm Harry. I'm an Inclusion and Belonging Advisor at DCHS. The first year in the trust was pretty normal, pretty standard, and then I got rushed into hospital with a medical emergency. Threw my life upside down. I mean, I've got two very young children, one 7 and one coming up 4. I'm on a waiting list to have my bowel out, so things have been pretty up in the air. I had a feeding tube in my nose up until a few months ago, so I suffered really bad with social anxiety, how I'd be perceived at meetings, and I can remember I turned up to a staff forum meeting and everybody was just so lovely, and our chief exec actually came over and wanted to chat with me, and I think it just shows what a people-based trust we are, because for someone of her stature and her job role to come and checking on a little fish like me was just incredible. I had no idea what a reasonable adjustment passport was. I sort of came back to work one day, I had a one-to-one put in my diary with my boss, and all she turned around and said is, right, we need to put a reasonable adjustment passport in for you or make it active for you. So she sort of just asked me what I needed around work and how they could make my day as easy as possible. It sort of fits quite nicely with the flexible working policy that's been triggered as well. So, like I say, I can just ring my boss or have a conversation with my line manager and sort of say, right, I've got an appointment on Monday. It's going to be at this time. So no, and say to me, like, forget the job for a second. Are you okay to be at work? Which is always lovely to hear. All the support I've received, like I said, the reasonable adjustment passport that's been put in place, the flexible working policy does massively allow me to be the best person I've probably ever been in an organisation. I think DCHS is a fantastic place to work and they really care about their staff.
So yeah, my name's Gurpreet. I'm a pharmacist. So as part of my job role, it's kind of quite a wide arching range, but it's anything to do with medicine. So I work mostly on our inpatient wards. I took advantage of the shared parental leave policy. So after the birth of my daughter in October 2019, my wife and I decided that we both wanted to spend a lot of time with our daughter. And I was off for a total of 6 months, 2 months alternating. The benefits are, one, you get to spend time with your kids, and that's so valuable because I'm finding out they've grown up so fast, and that time at the beginning was so valuable, spending time with them, bonding with them, learning how to look after them. And also you get to work with your partner, and so my wife really appreciated how I was able to help out with the kids, and we were both able to kind of continue with our careers. That's just amazing really to me. One, being able to give the care that we wanted for our kids, and then also continue our work as we wanted. The process of applying for shared parental leave, I don't remember it being complicated at all. I just filled out the form, sent it to my line manager, and I just remember one day an email arriving or something other saying that it's been approved. I had conversations with my managers before just to make sure it was practical, but yeah, it all worked out. It wasn't overly complicated. The environment at DCHS did make me feel comfortable to ask for shared parental leave. Our managers were really supportive, and so they're very friendly, they're very open to considering requests, and they do bend over backwards to accommodate the whole team's needs.
Thank you so much, Jane, but also to Harry and to Gurpreet as well. It's great to hear the progress that we're making around RES and DES and the further focus that we're giving in that area. It's also really good to hear how reasonable adjustments are made in practice. The one thing I just want to actually press around is that to ensure that we're real allies to our colleagues when we see that unacceptable behaviour, that is really important that we take action. So big thanks there, and now we're going to move into working in partnership, and we're going to hear from Heather Longbottom, Dominic Fackler and Deb Hall.
Thanks, Julie. Hi, folks. I'm Heather Longbottom. I'm a Divisional Director for Specialised Community Services. I'm going to talk to you very briefly about our Learning Disabilities and Neurodevelopmental Alliance that we have got between DCHS and Derbyshire Healthcare. We've had an arrangement in place together since 2021, and initially that was pulled together with an aim around improving stability and resilience of our services across our two organisations. There's about 250 whole-time equivalents of staff who are aligned to services that are delivered through this alliance. It's a fairly even split between ourselves and Derbyshire Healthcare, slightly more at Derbyshire Healthcare, but it's about sort of 57-43% split. When I came to this, which was around November last year, after our organisational restructuring our ops division, where I picked up responsibility for LD services, it wasn't overly clear if this was something that we were really trying to continue to jointly pursue. It's fair to say it was pretty rocky at that time. What I could see was there was loads of enthusiasm and passion for patient care, some brilliant working taking place at the front line between staff, irrespective of which employing organisation they work for, working together as a team to support our patients. But there were also quite a few unsaids, and to be honest, it was particularly at quite a senior level as well in our organisation. So I was finding there was real difficulties we were finding to progress some shared decision making around some key fundamental issues. I think it's fair to say there were a few trust issues as well. It kind of felt difficult to kind of go, what's it safe to talk about, what's safe to share, who's pulling their weight, who's not pulling their weight. It was that sort of environment that I sort of came into. And it's probably fair to talk a bit about there being potentially a little bit of a power struggle going on as well between organisations. There's a benefit. DCHS and Derbyshire Healthcare bring something very different to this partnership, and at that point there didn't seem to be a great understanding and development of the benefits of us together. So what we did, I'll be honest, it wasn't rocket science, but it was quite difficult at times. We had some really open, quite difficult discussions amongst senior leads of both organisations about how it was feeling for everybody concerned. We genuinely listened to each other's concerns, and we collectively made a commitment to do something about this as a partnership, as this alliance. We clarified some of those key issues that we were all wanting to resolve, and to be honest, which was sort of driving some of those frustrations as well that I'd sort of come into. And as a result, we've been able to overtly signal our shared commitment to the partnership, which has felt to be really important. So we've got a joint appointment of Fee, our head of service, and there's a shared line management arrangement there between myself and my colleague Lee in the Healthcare Trust as well. We've made a joint agreement to develop, and that work has started to develop, a shared electronic patient record, which is absolutely vital if you can think about patients who are moving across this LD-ND pathway. Depending on which organisation they are aligned to, can be quite tricky when their patient record isn't able to be shared across. So that's a really fundamental piece of work that's happening at the moment. There's also been loads of work around governance, oversight and clarification of how we are assured of the quality of the services in the alliance, and making sure that that meets the needs of both of our organisations without causing duplication of papers and meetings and such like for individuals involved. We've also made some quite specific open expressions of the partnership. So we've ring-fenced recruitment to vacant roles when they've come up, and we've ring-fenced them across both trusts, irrespective of where the budget currently sits for those posts as well, which we felt was really important. And we've made some very difficult decisions in recent months as well, and we've made those decisions together rather than in isolation of one another. So where next? I think it's fair to say we're still working through some of the tricky things in the alliance, but we are working through those together. Electronic patient record development is hard. It's hard work, and it's a hard nut to crack, but we're working on that. The understanding of our finances, how much money is in the overarching element of the alliance, where that money sits, how do you manage financial risk, it's all of that is quite difficult to work through. We've done a lot of work around those aspirations and the intent of the alliance, and the key focus for myself now is on trying to turn some of those wider aspirations, like I've said, into a reality, and really challenging myself to stay in that very uncomfortable space sometimes of trying to get a existing system to achieve a new kind of aspiration. And what might be quicker and easier but not the right thing to do is where we tend to sort of shoehorn something that we're trying to achieve into existing systems and processes. We need to stay in that slightly more uncomfortable space. So we keep talking, we keep staying curious, we keep asking a lot of questions, and there's a lot of sleeves that are rolled up to really try and resolve those tricky issues that are really making our partnership stronger every day.
Thanks, Heather. Are we handing over now to Deb or to Dominic? Dominic.
Hi everyone, I'm Dominic Fackler. My job title is Head of Community First in DCHS. My job is a direct result of a collaboration between DCHS and Derby City Council that we've been working on together for a number of years. So we've had for a long time services in DCHS that work really collaboratively with services in the City Council, where we support people either who are at home to try and help prevent them from being admitted to hospital unnecessarily, if they have something like a chest infection, or they've had a fall or something for people at home living with frailty that might tip them into requiring hospital treatment. If we can support them safely at home, then our teams will go and support them to do that. And equally, we support people when they're being discharged from hospital who often got long-term conditions or living with frailty, to support that transition from the acute environment into their own home, where we do a joint assessment of the long-term health and social care needs, help make that transition and help plan their long-term care with them. For a long time, the social care element of that was provided by Derby City Council, and the healthcare element was provided by DCHS. And you can see that there's a clear need to collaborate because most people in these circumstances have both health and social care needs, which need assessing and addressing and support with. So we've worked closely with them for a long time. In May this year, the two organisations took a big step forward in order to move that partnership forwards. So we transferred, after a lot of work with the services and the teams, we transferred all the services involved within that into DCHS to create one new Community First team, which is a combination of the community services in DCHS and the Home First services from the council. So it's Community First in name, but it's also Community First in ethos, because that's where we collaboratively want to work together to support people in the community in their own home where it's safe and appropriate to do so. So we're now proud in DCHS that we have a hospital social work team for the first time. We have a residential home that we provide a service out of, which delivers short-term care only to people when they get discharged from hospital to help, again, make that transition from hospital to home, to assess their health and social care needs. So we have our health staff go in alongside the social teams, and then we support them back into long-term, into the community where they go back to their lives. This isn't a DCHS takeover. I need to be really clear about this. It's very much a partnership approach with the council. So we're still working very proactively with them to make sure that this service is a success going forwards. So we in DCHS do work delegated to us by the council. So we come together to monitor the performance, monitor how it's going, to address issues, to work on it together, to collaborate going forwards, to really try and make this service a success. So collectively, together with the council, we can support as many people as we can to stay at home, to remain independent for as long as possible, out of either long-term care or with as minimum care needs as possible. So in summary, that's where we are at the moment. We've got a long way to go, but we've taken really big steps and we're really proud of what we've achieved so far.
Thank you, Dominic. And Deb.
Thank you, Julie. Good afternoon, everyone. I'm Deb Hall. I'm the Head of Patient Experience at DCHS. And I want to share with you how we're making our volunteer programme more inclusive by focusing on the power of partnership. So at DCHS, we believe that working together isn't just limited to staff and patients, it extends to our volunteers as well. Partnerships are key to building an inclusive environment where everyone has the opportunity to contribute and grow. So we recognise that a truly inclusive volunteer programme starts with collaboration, and by working in partnership with local colleges, sixth forms and Job Centre Plus, we're not only opening our doors to a wider range of volunteers, but we're also ensuring that our programme reflects the diversity of our community. These partnerships are crucial because they allow us to tap into the potential of the younger generation who represent our future workforce. So partnership doesn't end with recruitment, it's an ongoing process. And once we've connected with our potential volunteers, we take time to meet with them individually to understand what their goals and interests are. Through this collaborative approach, we're able to design roles that are both fulfilling for the volunteers and beneficial to the organisation. And this ensures that our volunteers are engaged and that contributions aligned to what our needs are. So a shining example of the partnership is one of our volunteers, Matthew, who is currently on a pathway to education. And despite facing physical disabilities, Matthew contributes and has done for several months, 20 hours a week to the organisation, which is an incredible contribution. Matthew's a meet and greet volunteer at our community hospitals and is a delightful young man. He's got a zest for life, which absolutely shines through to everyone who meets him. He's an avid Derby County fan and he's really keen to tell everyone he meets that. And we get such positive feedback from both patients, staff, and also the college that Matthew attends. Matthew's success story illustrates how through partnership and tailored support, we can break down the barriers and create meaningful opportunities for everyone, regardless of their circumstances. We're also really proud to share that 2 patients from an eating disorder service in another trust who've reached a significant point in their recovery are set to begin as ward volunteers for us at DCHS. And whilst they may not be ready for paid employment, the volunteer role will offer them really valuable experience, structure, and a sense of purpose as they continue their recovery journey. This is another really powerful example of how our volunteer programme can support individuals with their personal growth while benefiting the organisation. In conclusion, our commitment to inclusivity is deeply rooted in the partnerships that we build, and by working closely with educational institutions, employment services, and our volunteers themselves, we're creating a volunteer programme that's not only inclusive but also vibrant and dynamic. And these partnerships are the cornerstone of the efforts to build a diverse community that enriches not only our organisation but our broader community. Thank you, Julie.
Thank you, Deb, very much. You can hear the passion and the enthusiasm. And now we move into our healthy communities part of the agenda, and we introduce Sally Hobbs and Laura Derbyshire. Welcome.
Hi, thanks, Julie. My name's Sally Hobbs. I'm the Clinical Service Manager for the Self-Management Facilitator team. Been asked to come today to talk to you regards our team and what we do for the healthy communities. So if we start by giving you a little bit of a whistle-stop tour of our service, because it is a fairly new service, and I'm aware there are still people out there not overly familiar with what we do, and Laura will give you some statistics and some facts about how well we do this and some patient and staff feedback. The Self-Management Facilitator team, it is a bit of a mouthful, so we're affectionately known as the Smurfs. We came about as a way to relieve some pressures on community nursing teams whilst keeping the patient at the centre of everything that we do. We work supporting not only the patients, but the patient's support network, and that includes their friends, their family members, carers, both formal and informal, and using advanced communications and behavioural change techniques. We've had a lot of input from clinical psychologists. We support the patients to be independent with a range of healthcare needs that include simple things like simple wound care, catheter care, injections, some injectable medications, and we have the time to spend with patients that historically community nursing teams, whilst under so much pressure, just don't have that amount of time. We've currently got 2 teams. We've got one in the north of the county and one in the south. They're quite small teams. In the south, we've got 1 district nurse, 1 registered nurse, and 7 unregistered team members. And in the north, we've again got 1 district nurse, 1 registered nurse, and only 5 unregistered team members. So we are really small, tight-knit teams. We receive our referrals from both community and acute settings. We've worked really closely with community nursing teams, looking at their existing caseloads for patients that we may be able to visit and work with them to see if we can get them to perform some elements of their care themselves. Our rapid response teams across the county also refer to us as new patients, new referrals come in, they refer into our team, which sort of stops those patients being referred to our already pressured community nursing teams. And we also have a team member on the acute hospital ward every day, Monday to Friday, and they're working with the acute staff. We're looking at patients who are ready to, will be discharged in the next few days. And we'll either work with them while they're an inpatient, if it's appropriate, to try to get them to be self-caring for a short, while they're still in the hospital, so they're self-caring on discharge. But then if we can't get them to that stage while they're an inpatient, we'll then visit them up, we'll follow them when they come home into the community, and we'll see people that way. So looking at the then and now theme that has been running through today, if we look at what used to happen previously, With patients on discharge from the acute trust or from the GP, they'll be referred into community nursing teams. And as everyone's aware, we've got an ageing population now with people with much more complex comorbidities, which was leading to an increased demand on our community services. Visits were taking longer, but we were needing to do far more for our patients. Because of the increased demand and the increased pressure on the teams, the time to have that quality conversation with a patient was really limited and reduced. To be able to take time with a patient to explain their health condition, to explain and educate on how we meet their needs and what they could do for themselves, and give them the time to sort of discuss their anxieties and their concerns, and to be able to practice with somebody how to do their own care. It doesn't all happen in 5 minutes, and the community nursing teams just don't have the time for that. Whereas a self-management team, we do give the staff time. That it's a much more supportive way of working things for the patient. And we found over time that previously patients were becoming much more dependent on nurses. Unnecessarily in some cases. It was just, there was a mindset that, well, the nurses will come and they will do this for you. That following the Smurf involvement, where we've promoted patient engagement, we've empowered patients to become much more involved with their healthcare needs. We've been able to have those quality conversations. We've seen quite a few behavioural changes where patients have become self-caring. And that in turn has led to a reduced pressure on community services. We've got much better collaboration between the acute and the community trust, because we are actually in the trust, we're working on the wards. And we've found that for patients, they've got a much better understanding of their healthcare needs. They've got that involvement in the care delivery, and this as likely can lead to a reduction in avoidable hospital admissions, because they're more proactive in managing their own conditions. So a little bit of where we've come from and where we are now. The team was launched as a pilot about 18-20 months ago in January 2023, and it was a 12-month pilot, and it was running just in Derby City. At the end of that 12 months, it had been so successful that it became a fully funded service in the Derby City area. We expanded into Amber Valley in May this year, and we've very recently expanded into Chesterfield and North East Derbyshire. At this time, the team in North Chesterfield and North East have only just begun to see patients within their own homes. We expect to have somebody on the hospital ward in Chesterfield sometime next month. So we're now covering 4 localities, which covers 12 PCNs and 70 GP surgeries. There's quite a large amount of, it's a large geographical area, and it's a lot of patients for such a small team, but it has been really effective to date. So we're looking at, once we are well embedded in the Chesterfield and North East area, we need to be able to get that into place first. We're looking at where we can go next, and we're considering other areas across DCHS, the other localities, maybe other DCHS services, also considering, you know, external services to DCHS as well. So that's our vision for the future. So I'll hand over now to Laura. Laura's the DN in the team in the south of the county, and she'll give you a bit more information about our team.
Hi, thanks, Sally. Yeah, so just as Sally said, we cover a very large demographic, which means that we do work with a large variety of multicultural populations, which means we have to utilise sometimes interpreters or different health literature in various languages, just to make sure that that patient has got that patient-centred experience for their specific health need, where appropriate. And it increases that level of understanding and their engagement with their own health, which hopefully is reducing that positive health outcomes for them. We utilise the network of existing services to do this as well. So we look, I call it the rule of three. So we look at the patient first, what their needs are ultimately, working with that wider support network if they need just a slight adaptation to those. So, for example, with enoxaparin injections, if they can't remove the cap but they can do everything else, have they got a family member that could do that for them? It's a very simple step that may be overlooked because of time pressures, but overall helps that patient to become independent. We'll link with, like I say, different care agencies. We work in residential homes as well, so things that can be done to make that patient's health better. We always look at what's appropriate for that patient, so it does actually work the other way, that actually if we go past that family support network, is it needing an appropriate onward referral, not just to district nurses but to wound clinics or other areas, GP practices, things like that. We have those in-depth discussions with patients, which again is led by that behaviour change clinical psychology sessions that we engage with. We're hoping this will promote that little bit of self-worth within that patient, so that they are important in their own healthcare needs and not disassociated from it, which has really been quite successful so far. The initial responses that we wanted to do, like staff morale as well and resilience, because we're very mindful as a service that we wanted to build it on the experience of patients and staff members and service users, stakeholders. And to do that, we collected feedback throughout the pilot scheme session, and we're still open to that feedback now. Generally, it's been quite positive that we've listened to the patient. Is a very popular theme, that we've sort of taken what their concerns are and sort of address those in a person-centred way. Staff have reported to being more involved in the actual delivery of the service, and they're more engaged and really excited to deliver.
You've gone on to mute, Laura. You've muted yourself, I think.
Is that better? I'm sat next to Sally, sorry, so I was on her microphone. Sorry, so I was just saying we're hoping to engage those patients and staff members as well. And the feedback we've had in the initial inception stage, that once the SMURF project was launched, the average referral rate to Derby City itself actually reduced by 10% in comparison to other areas where we could see that steady incline into the referral rate into community services, through obviously those ageing populations and the comorbidities that are increasing. On average, we are averaging a 85 to 91% success rate to enable patients to become self-managing, either with a support network or independently, which is really positive, and we're hoping to continue that as well. I'm sorry, I'm not sure how much you missed of me being on mute, so if there's any other gaps that you want me to plug, please feel free to ask.
Thanks, Lauren. Thanks for some of that evidence as well. I think it's just great, but the SMURF team, brilliant team, but also just hearing Dominic talking about community first, they're really, really important initiatives. On today, when we've had Lord Darcy's report, this just shows some of the things that we're doing that are a blueprint for the future. And talking about the future, we're now going to have that focus on the future and hand over to Amanda Kerry and Danny Connor.
Thank you, Julie. Hello, everybody. I'm Amanda Kerry. I'm the Improvement, Innovation and Effectiveness Lead at Derbyshire Community Health Services. So I'm going to talk today about how we're working on Focus on the Future, the piece of work that's ongoing about our waiting lists and how we can manage them differently. The Improvement, Innovation and Effectiveness team were approached to support an improvement and an innovation idea that had been discussed with Tracy Allen following an insight visit that a staff member had a conversation with. The project that we were working on was with the community podiatry team. They had a fantastic idea on how they could manage their waiting list in a different way, but they needed some help to bring that idea into action. So our initial meeting was held to support them, and we were focusing on a clear aim. And in that meeting, we agreed a few things. That was to agree the aim, which was to manage the community podiatry waiting list to enable higher risk patients to receive more timely care by offering alternative care solutions to lower risk patients. The team were really focused on wanting the safest gain for the patients and the staff and the service. And what we worked together to create was a group education session, and it does exactly what it says on the tin. It's about bringing patients together as a group to educate them with the conditions and how they can self-manage some of those conditions. So following our initial meeting with our community podiatry colleagues, we set up regular check-in meetings, and they were run at different times on different days, so we could include as many of the team as possible. The team that we're working with, they are clinical people who have clinical responsibilities and are working with patients. We created a network of stakeholders, and we're still doing so. That's really a still live ongoing part of this work, and that's about bringing key people in at key stages. We created an exec sponsorship, so we have regular meetings with Danny from the team, with our exec, to keep them up to date, and that's feeding information into us as well as feeding the information out from the project. We also signposted some external points of contact. So there was some examples of some work that had been done in the Sussex. There was some work that's being done within DCHS, so that's connecting some work that MSK are doing. And then even now we can connect with diabetes, where we've got a crossover where we've got patients who are on both waiting lists for diabetes and being treated for that, as well as the community podiatry. So our first meeting was about capturing our aim of the project, listening to the team's language and their priorities. I'll hand over to Danny.
Thank you, Amanda. My name's Danny Connor. I'm the General Manager for Podiatry Services. So as Amanda has said, the aim of the patient group educational sessions was to do something different with the lower risk patients that would enable us to see promptly those who need to be seen soon or urgently. As Amanda said, we had our first educational session in January this year, and whilst it provided a useful dry run, we realised we were not as ready as we thought we were. Changes were made, and we started our second session in April. Since then, the GES, the General Education Sessions, have expanded right across the Trust, and it's now very much business as usual. They are in place. It is important to note that the process took some time, but it was necessary to create that safe space for staff and enable them to see waiting lists differently. As a result, we have taken 173 patients off the waiting list and seen 124 patients. The data and information that we have developed around our waits has demonstrated that whilst we reduce the overall waiting list, we recognise our future focus is on those patients who continue to wait 65 weeks or more without a clear or defined way of when they will be seen. To address this, we are working with the transformational team and have put together a plan of action to bring the target of long waiters down to 52 weeks. The data also identified inequalities in the waiting time of routine patients, and we know that some groups were waiting longer than the average. Again, to address this and respond, we are working with the population health management specialist and colleagues in Health Watch to engage with patients and try to make sure we get feedback we can act on to know why things were difficult or very difficult to access our service. In summary, the work we have done has led us to do things differently with our routine patient. It's given us a greater focus on how appointments are arranged for routine patients and an understanding of who is waiting. An engagement process is underway to identify any barriers to how patients across the service access it, and how existing patients who need us, but not only those who access the service, but those who have not approached us as yet. Thank you.
Thank you both, Danny and Amanda, and just great pieces of work, which is so important when we've got long waiters. We're continuing with a focus on the future, and we're now going to hear from Ian and Erin.
Hello, I'm Ian Murray, Capital and Estates Programme Manager. and I'm Erin Marshall, Capital and Estates Improvement and Development Manager.
DCHS Estates team is over 50 strong. We have colleagues based all over the county. We look after over 150 buildings, including GP surgeries. We have 70 grounds and garden sites that we maintain, and we serve a population and clients of over 7,000. Since 2013, DCHS has been responsible for maintaining and developing a wide portfolio of estate across Derbyshire, much of which was transferred to DCHS from the previous PCTs. The buildings vary in age and condition, ranging from old workhouses dating back to the 1840s to newer Lifco buildings. Our estates department ensure the safe and efficient operation of the Trust's buildings, engineering systems and vital patient equipment, and is responsible for maintaining buildings to the highest possible standards. We've gained a reputation for providing a quality service and are proud to be one of the few NHS estates departments nationally to have BSI ISO accreditation for quality and environmental management. Our service is also recognised within DCHS and by system partners as being responsive in unexpected events, supporting sites in the event of floods, leaks, and responding to break-ins and accidental damage, and the occasional car versus building incident. The estates team were also pivotal in setting up COVID vaccination hubs across Derbyshire in 2021, transforming buildings such as theatres, community halls and sporting venues into mass vaccination centres, enabling the rapid rollout of the vaccination programme. NHS Estate is one of the key enablers to change in the healthcare system, and good quality fit-for-purpose facilities and equipment are essential for the delivery of high-quality care to patients. Developing community care estate is critical to enabling integrated care systems to provide more out-of-hospital care closer to patients' home, and this requires careful strategic planning with system partners and proper investment in the estate. Our estate strategy sets out a 5-year plan for managing our buildings and the aim of aligning our estate with service objectives so we can provide the right facilities in the right place at the right time. It also helps us to answer questions such as where is capital funding required and how can we minimise backlog maintenance or running costs.
So we use a tool called a 6-facet survey to assess the condition, quality and functional suitability of our buildings. And this helps us to identify backlog maintenance costs and identify buildings that are no longer fit for purpose. And this forms the basis of our capital plan.
A simplified definition of capital is expenditure of at least £5,000 for long-term investment in buildings and maintaining NHS land, facilities and equipment. Across the NHS, capital investment accounts for a small share of the total health spending. Despite low levels of capital funding over many years, DCHS has maintained a robust capital programme and significantly invested in our estate.
A good example where 6-facet survey findings, strategic estate planning and capital investment can be seen in action is the development of our estate in Heanor, where we owned a hospital and a health centre, both requiring significant backlog investment. DCHS invested £3.4 million in a new health centre on the site of the former hospital and gained a capital receipt for the sale of the Heanor Clinic site.
In recent years, there have been opportunities to access national capital funds to support system estate priorities. Babington Hospital in Belper and New Home Hospital in Bakewell, both former workhouses dating back to the 1800s, have significant maintenance needs, outdated infrastructure systems and challenging listed building status. DCHS have successfully bid for £14.92 million STP funding to replace the existing facilities with new buildings to the value of £26 million. New Home Health Centre incorporating Bakewell Ambulance Station is due to open to the public in September this year, and we are about to commence work on a new health centre on the site of the former clinic in Belper, which is due for completion in early 2026. Unfortunately, our bids for national funding for a much needed development in Buxton have so far been unsuccessful. We continue to work with system partners and to explore funding opportunities to be able to continue with our plans for new development in this town.
So in parallel with our estate strategy and capital investment plans, we also continue to review how we're using our estate. Since February 2023, DCHS have used room occupancy sensors to gather information about how clinical and office space is used during the day. And the findings of the surveys, along with data from our Planet FM system, are enabling our site optimisation group to identify opportunities for improving utilisation, driving efficiencies and exploring different ways of working.
As DCHS has a significant property portfolio across Derbyshire, we've been able to work with system partners to optimise the use of the estate and increase access to services such as diagnostics. Joined Up Care Derbyshire has received funding to develop 3 community diagnostic centres at Whitworth, Ilkeston and Walton hospitals, increasing capacity and improving our local access to a range of diagnostic services, making it quicker and easier to get a diagnosis. Since the 2020 introduction of capital spending limits and funds shared with partner organisations, DCHS has had less flexibility than we would have previously afforded as an NHS Foundation Trust. And this, along with challenging approvals process, will continue to be significant barriers to capital investment for DCHS. But we remain committed to improving, developing and rationalising our estate within the current financial constraints that we are facing.
However, despite these constraints, we've had much to celebrate in recent weeks, with the turf cutting at Belper and the keys handover at Bakewell, marking major milestones in 2 big developments which will future-proof health services for local residents for years to come.
Thank you so much, both Ian and Erin there. I just want to say the estates function and capital is really about bringing together all parts of our strategic themes. So important. We are running a little bit behind time. This is some time for questions or reflections. But just to start off this short section, I'm going to ask 3 of my non-executive colleagues to just give their reflections of the year. So there was a little bit of who's going to go first on this. So being chair, I've made the decision that we're going to go Asma, Mark and then James. So just a few thoughts about your reflection on the year. Asma.
Hi, thanks, Julie. I'm Asma Nafis. I've been an ed here for 3 years now. And I think my reflections on the last year, it's been a year of collaboration. It's been a pleasure to witness the collaboration and our relationships with system partners going from strength to strength. We heard about the ND Alliance from Heather earlier. We've had various board-to-board sessions, and I've really been able to see that they have resulted in improving services for our citizens. Secondly, the evolution of our board dynamic and that focus on what it feels like to work for or be served by the trust, the kindness into action approach that's been implemented. As a board, we have a culture of respect and teamwork, and we all bring a different perspective. And in the last year, we've had real thoughtful discussion with an increase in the use of data leading to robust decision making. We've also had a real focus on belonging and inclusion, which we heard about earlier today, and what it feels like to be served by our work for DCHS. As Julie described earlier, all about the people is the real golden thread for the board. And on a final note, personal enjoyment. I've been here for 3 years now and I feel privileged to be part of DCHS. It's incredibly fulfilling. There's a real sense of pride in how we live the DCHS way, that common sense of purpose in improving patient care and staff wellbeing, and the optimism that our incredible executive team and DCHS staff extol in all that they do. Thank you.
Thank you, Asma. Mark.
Thank you, Julie. And I'll follow on from Asma there with a few reflections. I've been a non-exec with DCHS for just over a year now. Well, it's actually 18 months. It's been a privilege. And I guess just a few observations in terms of assurance of how the board fits with the workings of the whole organisation. And so 3 areas perhaps. One is there is a constant, and I observe it in everything we do, and the messages we've seen today in the videos, of looking for collaboration, looking for innovation, and pushing away barriers, internal or external, to get at the heart of issues. There's some really tricky stuff around us, and it gives great hope and optimism that we've got that sort of approach and starting to make progress in some of those tricky areas. There's also a tight grip on connecting our people and our patients and our community and our finances together, so that every conversation, whichever way you look at it, always comes back to, okay, the impact on the person. So again, as we go into some very tight financial constraints, the assurance I see and take is that we always come back to that. So what's the impact on our services, and can we improve those services? And lastly, the third point is we have a collection of different voices. We have a collaborative and challenging makeup as a board, and those who work with the board. And we respect each other by listening to different views and challenging those views, but it's always with respect, and it's always to land on something we can push and encourage and support collectively. It's great. It's a privilege to be here. Thank you.
Thank you, Mark. And finally, James.
Good afternoon, everybody. I'm James Riley. I've been a non-executive director with DCHS for the past 8 and a bit years, and it's been a great journey, which I continue to enjoy very much. I think if I reflect on the last year, we can't avoid the fact that it's been a very tough year, in the sense that you've seen from the presentations that demand on our services has increased. The complexity of people's needs has increased. The acuity of some of the people we are supporting increased, and there are 4 or 5 of our services, some of which you've heard today, who are wrestling with waiting times, which means that for some of our patients and our citizens, we're not providing the service as speedily as we would want. This is something the board is very mindful of. But as you've also heard from our presentations, the ambition towards service improvement and quality improvement remains completely undimmed, and there is a passion for this that is reflected right across the organisation, from our executive leadership team through to our frontline staff, some of whom you've heard today and who we are very privileged to engage with when we as non-executive directors go out for what are called insight visits to see that. So that passion for service improvement continues to bear fruits. I think we've made massive steps forward in realizing our ambitions to work collaboratively in an integrated way, and you've seen those results again demonstrated in the presentations today. There are other services we could have presented where that is really manifest. I think too, I'm very struck by the fact that we hold in balance the need to provide good quality services wherever they are, the need to transform, and the eye towards what is the future bringing for us and how can we rise to those challenges. I remain in awe of how our leaders and our staff respond to that, remain very positive, and I remain very encouraged, despite some of the difficulties we're all facing, our patients and our staff ourselves, that we get very encouraging positive signs from both staff and from our patients that they remain confident in and value very much the services that we deliver. Thank you.
Thank you, James, very much. Can I ask if there are any questions at this stage? There will be another opportunity later today. Okay, can I ask that we come back at in 5 minutes time at 2:12. I know that's very precise, but we have still got quite a lot to cover. So at 2:12. Welcome back. I hope everybody had time for just a short comfort break there. I'm going to hand over now to Tracy Allen and her executive team. This is Tracy's last AMM. It's actually her last day. And I'm going to be just mentioning that a bit later, but over to you, Tracy.
You've stolen a couple of my lines already, Julie. Thank you. We can't possibly do justice to the huge range of work that my colleagues, our colleagues across the Trust, have done during 2023 and 24, and the difference that that work has made to citizens in Derby and Derbyshire. And so I would really encourage people to have a look at our annual report and annual accounts, which have been signposted throughout this meeting. They're a really good read, and they will give you a much fuller picture of the things that we were up to during that year. I do hope, though, that the fantastic segments that we had in the first part of the meeting have given you a real flavour of some of the things that we spend our time doing and the progress that we're making in terms of what is quite a challenging environment, as James summarised at the end of that session. And I'm going to hand over to some of my exec director colleagues just to pick up on the themes that were in those segments and give you a bit of a whistle-stop tour of the key things that we delivered in 23-24. But before that, I do want to make a few key points about the year. So if we could just pull up the next slide, please. Thanks. So 23-24 was our 13th year as a trust, and my 13th year as its chief executive, and we maintained really strong performance across the range of the things that we are responsible for delivering on an annual basis. We ended the year again as what's called a segment 1 NHS provider, meaning that we're delivering in the top tier in terms of performance across the NHS. And we delivered on all but one of our statutory objectives. The one we didn't meet for the first time in the Trust's existence was the requirement to deliver a balanced financial position over those 12 months. You'll see from Pete's presentation in a minute, despite delivering more than £9 million of financial efficiencies, the overall financially constrained position of the NHS and Joined Up Care Derbyshire meant that the board could not see a way through planning for break even whilst maintaining what we regarded as safe, sustainable services, given the demand that we were facing. So we planned, as I said, for the first time to deliver a modest deficit. We actually did slightly better than our plan, but we didn't come in balance. In this year, 24-25, we are planning to deliver a balance, and Jim may give a bit of an insight into how things are going with that towards the end of the meeting. As Julie's flagged, it was a really important year where we revised our 5-year organisational strategy, and you've seen the 4 key themes of that, which now frame everything that the organisation does. What I'm really proud of is how that strategy was written by people within DCHS, by patients, by partners, and with a lot of engagement from citizens. And I hope that you can see the importance of those themes in the work that we're reporting on today and the work that my brilliant colleagues across the organisation do every day. And then we also developed an operational plan for 23-24 that was based around those strategic themes and aligned to the wider aims of our Joined Up Care Derbyshire integrated care system. If you flick onto the next slide, you can see those 10 priorities in the plan. We made really good progress on most of them. We've already heard some fantastic work from Jane about the workforce, from Heather about partnership working, and Dom around our partnership on ND with Derbyshire Healthcare, Community First, the partnership with Derby City. You've heard our fantastic Smurfs and Danny talking about work around reducing health inequalities in some of our services, and from Ian and Erin on the optimisation of our estate. The couple of things I did really want to pull out, though, follow on from what Danny was talking about around podiatry. We had an objective at the beginning of the year to not just reduce the overall number of people waiting for our services, but to try and reduce the length of time that people were waiting. And despite overachieving on the amount of activity our brilliant colleagues did overall across all our services, we didn't make the progress that we wanted to on reducing the waits, the longest waits that some people in some services were facing. We've gone into 24-25 with the waits that are not acceptable. Danny was talking about people waiting more than 65 weeks for podiatry. We've got people waiting that long or will be waiting that long for our weight management services. And we've got people waiting over 52 weeks for our vasectomy services. And I want to apologise to people who were affected by those long waits on behalf of the board and our colleagues. As Danny and others have said, that's a real focus this year. We've put in place a lot, or our colleagues have a lot of innovative ways of delivering services, as Danny described, and they mean that we're confident we're managing to kind of clinical urgency needs, but we now need to focus on getting those longest waits down because we don't believe that those are acceptable. The other area that I wanted to flag that I'm not sure will come out was our urgent treatment centres, where again 23-24 was a year of real challenge, and that challenge has continued into this current year. During 23-24, our urgent treatment centres were dealing with a really big increase in overall demand and an increase in the number of people presenting to them with illnesses, as opposed to their more traditional work around minor injuries. And this really caused some challenges for us that resulted in us during the year having to consolidate our staff across the 4 units that we operate out of and reduce the services available at Ilkeston on an interim basis so that we could be sure that we were running safely, and to give us the space to develop a plan to manage that new demand in a really sustainable way going forward. That plan is still working through. So whilst we've been able to slightly extend what we're doing at Ilkeston, we're still not providing the full range of UTC services across all 4 of our urgent treatment centres that we'd like to. And the board remains really focused on tracking progress with a plan to ensure that we can get to that point with the right number of skilled colleagues able to see the people that are turning up and wanting our support from all 4 urgent treatment centres later this year. We've talked about the integration with local authorities and with our other partners. I just wanted to pick up on the bottom bullet point there around the work that we're doing with our local authority partners, particularly Derbyshire County Council, on services for children and young people. We provide children's services, 0 to 19 services on behalf of Derbyshire County Council, and they're as financially constrained in local authority world as the NHS are. So a really big focus during last year was working closely with the council to work through how we could redesign our children's services to fit within a reduced financial envelope that the council had to invest in those services. And I'm flagging it because we're currently out to consultation with the County Council about the proposals that our colleagues worked up last year. So if that's a service that you're particularly interested in, a user of, please do go and have a look at that. If we can move on to the next slide then, please. We continue to play a full and active part in the integrated care system. That's Joined Up Care Derbyshire, JUCD. And I've already referenced the very significant financial challenges that the whole system had. We ended the year as a system in deficit, and all the partners, NHS partners in the system, were in deficit. We were also required to work together to manage the very sustained periods of industrial action that you will be aware that the NHS suffered during last year. Because that industrial action mainly involved doctors, DCHS was not hugely directly impacted in 23-24, but we were indirectly affected, and have had to step up and support those parts of the system that were directly affected, making sure that we could still maintain the flow through the acute hospitals where most of the impact was felt. Julie's already referenced that as we came out of last year, we were facing a change in government, and I'll let Jim pick up the story around how things have already started to change under the new government, and particularly the publication of a really important report, the Darcy report, that I think will shape Joined Up Care Derbyshire and DCHS's future over the next couple of years. So if we then move on to the last slide, please. As Julie's already said a couple of times, at the end of 23-24, I shared the news that I'd be stepping down as the DCHS Chief Exec, and in fact, today is my last working day. So my annual thank you to all my colleagues across the organisation and the incredible volunteers and community groups who support us is even more heartfelt than it usually would be. It is the brilliant people and volunteers who make DCHS the great organisation it is, and I want to thank every one of them for their contribution to 23-24's achievements and for the care and compassion that they bring into work every day. Now, I've done a long stint in Derbyshire as the DCHS Chief Exec, but my efforts are minuscule in comparison to a couple of people that I wanted to pull out for special thanks at this meeting. And that's to two incredible members of the extended DCHS family, Pam Wildgoose and John Briggs, from the Matlock Hospitals and Ripley Leagues of Friends, respectively. John, who I think I saw join the meeting earlier, has been the Ripley League of Friends treasurer for 50 years this year. And Pam, who celebrated her 93rd birthday in June, has been the honorary secretary of the Matlock Hospital League of Friends since its establishment in 1967, which was the year before I was born. And I know that everybody on this call will want to join with me to offer huge thanks to both of them from all of us at DCHS for the difference that they've made to local health services, and to ask them to share our thanks with League of Friends members that they work with, because we wouldn't be the organisation that we are providing the services that we do without your league's incredible efforts. So thank you both for being such absolute troopers. I'm absolutely delighted to be handing over the CEO reins to an internal candidate, to Jim Austin, and you'll hear from Jim in a minute. Jim is somebody who absolutely epitomises the DCHS way. He's already played an incredibly important part in the trust's development and success, and I know that he will be a fantastic chief executive. Thank you. So I'm going to hand over to Michelle, who's going to just give us a whip through some of our quality service achievements.
Thank you, Tracy. So good afternoon, colleagues. My name is Michelle Bateman. I am the proud Executive Director of Nursing, Allied Health Professionals and Quality for DCHS. I also have the role as the Director of Infection and Prevention and Control. So what I hope to do today is just to pull out some key pointers regarding how we at DCHS understand the quality of the services that we provide and how we can offer assurance on understanding that quality, but also taking action when things don't go right. Each year we know is a challenge for health and social care delivery. And you've already heard some of those examples from Tracy, the waiting list, the challenges within our urgent treatment centre. But hopefully what you've also heard is despite these challenges each year, our staff rise to the challenge to ensure our service users have a safe, if not always quality service. We may not always get it right, and when we don't, we seek to understand, to learn and to do better. And even when we get it right, we seek to understand, to learn and do better. We've already referenced the trust strategy, which has a powerful strapline. If it matters to you, it matters to us. And demonstrating quality of our services is a measure of how successful we are in bringing that statement to life. We know that Lord Darcy describes quality as being comprised of patient experience, patient safety and clinical effectiveness. And each year we outline our achievements against each area through our annual quality account. And because I won't be able to do it justice in the time that I've got, I would support Tracy to say, please, if you have the opportunity, it is an amazing read to really understand the breadth of what our staff do within DCHS. This year, out of our priorities, we've managed to achieve two of the three. And we're committed to continuing to work on ensuring we understand what is stopping our service users knowing how to give us feedback, as this is a key way of being able to measure the quality of our services. So quality improvement. Knowing that we are providing the most appropriate service is important. One of the key programs we have to help us recognise when quality may not be as we would want for our service users is our Quality Always approach, which we are proud to have had identified as a finalist in the HSJ Patient Safety Awards. This approach, which is supported by over 1,200 quality and safe care champions, helps us have an overview of good practice, whilst also identifying those services which require additional support. In addition to that, as referenced by James, we have our Board Insight Visit programme, which enables board members to speak directly to staff and correlate what they are hearing with what is being reported to board. During the year, we continue to invest in our quality improvement through the Quality Service Improvement and Redesign programme, known as QSA. This seeks to empower our staff with the tools and techniques to consider measurable service improvement, which not only benefits our service users, but also helps develop staff with new skills to demonstrate the effectiveness of what they do on a daily basis, building on our 8 quality improvement principles. We continue to be committed to be a community provider known for its research activity, and we continue to promote the culture of research and innovation, not only by increasing our patient participation in research, but giving our staff empowering our staff to feel confident in delivering research themselves and taking research forward. As Director of Infection Prevention and Control, I'm pleased to report that we continue to demonstrate compliance with the Health and Social Care Act, Code of Practice for Infection Prevention and Control. Throughout the year, we reported low levels of infections across all of our services, and where we had COVID outbreaks, these were investigated in a timely manner to identify learning for the broader organisation. In terms of care innovation, you've already heard examples of innovations that are taking place across the whole organisation, and we are never standing still. We're always seeking to learn, develop and improve. Our dementia palliative care team have worked with the NHS England to develop a national toolkit as a blueprint for dementia palliative care services, which has been promoted both regionally and nationally. And during the year, we welcomed the Deputy Chief Nursing Officer for England when we had the opportunity to showcase our dementia palliative care team and our wound care clinics. The wound care clinics in particular continue to grow and develop to meet the needs of our service users, developing sessions for those who would not routinely engage with these services. Following a story presented by our staff to one of our quality service committees, we've also worked with Derby University to develop and deliver a new adult and children's continence training course in the absence of a similar course being available locally. And the uptake of this course has been phenomenal. As DCHS, we continue to strive to understand who is able to access our services and who isn't and why. And this is so important if we are to fulfil our ambition of reducing health inequalities. This, alongside the work we are doing to understand the potential for clinical harm to those who are waiting for treatments, means that we can be more responsive to the needs of our service users and our population across Derby and Derbyshire. As an organisation, we continue to be rated outstanding by the CQC. And we are proud that 93.9% of our service users recommend us as a place to receive care and treatment. When we don't get it right through complaints or incidents, we will always seek to understand, learn and do better. But I am so proud to be the Executive Director within this organisation, working with a phenomenal team. And we will always continue to do the right thing for the citizens of Derby and Derbyshire. Thank you, Tracy.
Thank you, Michelle. So I'm handing over now to Darren, who is our Deputy Chief Exec and Chief People Officer. Over to you, Darren.
Thanks, Tracy. Good afternoon, everybody. I'm Darren Tidmarsh. I am the Chief People Officer and the Deputy Chief Exec for DCHS. So during 23-24, as part of our strategic aim of putting people at the centre, we spent the majority of our time trying to continue to embed the NHS People Promise. The People Promise comprises of 7 promise statements. We are compassionate and inclusive. We are recognised and rewarded. We have a voice that counts. We are safe and healthy. We are always learning. We work flexibly, and we are a team. We set out to achieve 3 things. The first, to retain people by keeping them engaged and looking after them well. During 23-24, we maintained a vacancy rate of below 3%. When we compare that to our peer average of just over 8, you can see the importance of that. And our turnover rate was less than 10% during 23-24, which puts us in lower quartile for community trusts. You might ask, why is this important? Well, it's important for quality with continuity of care, for safety, because people who work substantively for us understand our processes and our procedures and understand our culture. And it's important for our costs, avoiding recruitment, training and agency costs. In terms of well-being, during the outcomes of the NHS staff survey, our colleagues generally say that DCHS believes that we as a trust are considered the well-being of our staff important. We have a range of proactive support as well as reactive support through occupational health and our own in-house counselling service Resolve. We set out to invest in people's talents and skills. We further developed our career pathways. We had the highest number of active apprentices, 144 at parts throughout 23-24 across 29 different disciplines. We focused on entry roles in support of our role as an anchor organisation, and we signed the Care Covenant, providing employment for those leaving care, as we understand the importance of employment as a wider determinant of health. We saw further cohorts of the Derbyshire nurse, our innovative rotational programme for newly qualified nurses working across providers and general practice, and we've been shortlisted for the Nursing Times Award for this work. We know we have more to do to increase the diversity in more senior roles through targeted support, and this is something for 24-25. We wanted to create a workplace where everyone feels welcome and valued. In partnership with Derbyshire Police, we continued our work around zero acceptance of abuse and discrimination for our staff, from colleagues and from patients. And People Services, our renamed Embrace Network and Freedom to Speak Up Guardian, continued work to encourage people to speak up. We've introduced our Kindness into Action, embedding kind and compassionate culture. We signed the NHS Sexual Safety Charter in February 24, and in March 24 we held our second Staff Networks event, Inclusion Conference. This time we were really clear, it wasn't just for our networks, it's for everyone. Again, we received powerful insights and we heard some really heartwarming stories. We've made good progress, as Jane has indicated, through our data for both our workforce race equality standard and our workforce disability equality standard. And I'm particularly pleased with the improvement that we made around the recruitment indicator, bringing it below 1.7 the first time. But there's still more to do. Too many of our staff indicate instances of bullying, harassment and discrimination from colleagues or from patients. We made a successful bid to the NHS Charitables funding to provide an enhanced support for those with neurodiversity, and our Armed Forces Community Network has been shortlisted for the HSJ Military and Civilian Partnership Award. During 23-24, we had an increased focus on looking after our staff in terms of their health and safety. We focused on violence and aggression and lone working arrangements, and we received significant assurance on an internal audit. One of the People Promise themes is that we have a voice that counts, And in January 24, we relaunched the Staff Forum with over 50 staff representing colleagues from all parts of the Trust. And we've really started to get into some of the issues that affect staff as part of their work for us. 2 questions in the National Staff Survey stand out for me. Would you recommend DCHS as a place of care for a friend or relative? And would you recommend DCHS as a place to work? We received scores of 84% and 74%, putting us the highest community trust for the former and among the top scores for the latter. I've just seen the Q2 NHS Pulse survey results and the national benchmarking. Really pleased that DCHS remains well above the national and peer averages for all indicators. Thanks to all our staff, but a shout out to all the people service teams who support all of this work and have made many transactional improvements to the way that we do things, with a greater focus on what this means for teams providing care, and to the comms team for pulling the work together for this afternoon's AM. Next slide, please. I've got that one. As for all the good work that we've done around staff wellbeing, our scores in terms of staff morale and engagement from the NHS survey, we were selected to join the national exemplar site for NHS People Promise. And this will be the focus for our work in 24-25, where we continue the implementation of the NHS People Promise with a focus on wellbeing, leadership, staff advocacy and the inclusion of everyone, enabling all to have a voice and be involved and feel valued. We'll make sure that we deliver our 24-25 workforce plan with due reference to the National Long-Term Workforce Plan and its underpinning principles of train, retain and reform. We'll support the enabling functions of achieving operational efficiency and improved productivity, and including the embedding of a culture of continuous quality improvement. And finally, I'd like to give a personal thank you to all of our staff for everything that we've achieved over the last year. Thanks, Tracy.
Thank you, Darren. And then last but by no means least, handing over to Pete, our Chief Finance Officer. Pete.
Thank you very much, Tracy. This has been the first full year of my working life at DCHS and coincided with the first year of making a deficit. So I hope there isn't a correlation between the two, and we'll be doing something a little bit different, hopefully in 24-25 to make sure that that doesn't happen again. There are some really key highlights from the year, but I think it's important to remember where we started. We knew that the planning round that created the 23-24 plan was really difficult, really trying. We went through a number of iterations as to what that would look like for us as an organisation, and we ended up with an efficiency target which was higher than we'd ever had to achieve previously, and that created significant challenges in terms of the way that we would organise our business to be able to deliver that, and also to deliver the really key services that we needed to make sure that we did our best for residents and patients within Derbyshire. So within the targets that we set, there were some key highlights. I think the first thing to say is that as part of that efficiency saving target that we set, we were intent on a break-even plan as being our starting position. And it became rapidly clear to us as we headed through the first part of 23-24 that in particular issues around inflation and some other related matters to do with operational costs that were arising would make it incredibly difficult for us to achieve that as an ongoing position. And along with the rest of our system partners, it became clear that we would all be amending our positions into either, for a lot of them, into a large deficit, and in our case, moving from a break-even into that deficit place. So very challenging place we started from. Things did improve as we went through the year in that the efficiency savings target was met, that the hyperinflation that we were experiencing at the start of the year did start to mitigate as we got towards the end of the year, but did create that significant pressure on delivery for finance staff and for budget managers as a whole. Having said all that, at the end of it, we came in with a final position which was slightly under the deficit that we'd agreed for us as a provider, and the system as a whole just about achieved the level of deficit that was deemed acceptable by NHSE. What it does mean is that there were some really good messages from us from a financial position. They are that the external auditor could agree our accounts on a going concern basis, which is always a great place to start. and also that they gave unmodified opinions on the accounts and our ability to achieve value for money. Again, really good positions to be in, gives you a really good basis for moving forward, and allowed us to get our accounts agreed, signed off, and into the Secretary of State for approval in line with the national timelines. And as Tracy alluded to earlier, we also managed to retain our segment 1 status as part of the oversight framework, and again, that's a really good position to be in. It means you've got minimal or the minimum of oversight from NHS as to what we're doing, because they trust us, that they accept that we're doing the right sort of things, and the financial position was a key part of that. Within the work that we've done, we've had the opportunity to put together some really fantastic investments over the past few years, and in particular, we got to the fruition, hopefully now, of the new home health centre, which replaces the old building, and which was opened, or the keys were handed over, should I say, relatively recently to Tracy as one of her final acts, and that's a really fantastic facility, and as shown on one of the later slides, also produced some really good sustainability benefits for us as an organisation as well. Alongside the Bakewell build, we've also had 2 community diagnostic centres which are either open or due to open, and we've also got the new healthcare hub, which has finally got approval, and we've got the money for it, and we're starting to get on with the build to replace the Babington site, and that can only be absolutely fantastic for residents and patients around that area as we move into something which is a bit more 21st century rather than an old workhouse, beautiful building as it is. And as Tracy alluded to earlier, we've also been really well supported by League of Friends, and in particular the Matlock League of Friends, who contributed another significant amount towards activities at Whitworth Hospital, and that's really helpful in terms of us managing our resources and getting the best bang for our buck in terms of what we can deliver. Thank you. If you could just move on to the next slide. We then move on to some of the more interesting, I would have said, targets rather than just looking at the bald finances. So on sustainability, we've continued to do well in terms of reducing our emissions, heading towards the net zero target for 2040. Some really significant milestones in there, and in particular, it's interesting to know that the mileage levels are still staying below the pre-COVID levels. That's a really good message, because of course they took a real dive when we headed into COVID, which was to be expected. There was always going to be a bounce back, but we've managed to maintain a 14% reduction, so that's a really good place to be. 49% overall reduction in carbon emissions over the 6 years to 2023, again heading us right onto that sort of path where we hopefully can get close towards achieving the net zero target, if not achieving it. And then we've got, as I alluded to, that the 95% carbon emissions reductions on new home, and hopefully something similar with the Belper site. They're really major contributions towards us achieving our aims around carbon neutral. There's also been significant work taking place on transformation, and transformation can quite often be thought of simply in the savings field, and it does have hopefully a very important role in helping us to achieve ongoing, really significant and structural savings that are sustainable for the organisation as a whole. However, they not only do they provide savings, they also provide a way of improving what we do and improving the services that we offer. And there's been a great deal of work that's taken place. Some of it's been alluded to in the presentations that we had earlier. So there's the piece around what we're doing with our workplaces, and that's a really good example of some of the efforts that we're trying to put into improving the services that we offer and getting them in the right sort of place. And we can be really proud of, not only in terms of what the staff do in terms of delivering those services, but the facilities that we've got and the experiences that people have when they come and visit us. Moving on, that does give us some significant challenges though for 24-25, in that we thought our savings target was really stiff for 23-24, but we were pushed further again into 24-25, and at 5% of our overall budget, it is now the largest figure that we've ever had to achieve. Amazingly, we're doing really well at getting quite close to that figure so far, and we've got a little bit of a way to go to be able to push us there as we get towards the end of the year, and that's a really amazing achievement by everybody involved. The key challenge for us, because that does sound really good, is making it as recurrent and as sustainable a set of reductions as possible, and certainly building a plan for 25-26 onwards, which has got transformation at its heart and is delivering those sorts of long-term savings which deliver on a recurrent basis. There's a few other things I perhaps just want to add, just perhaps looking forward a little bit. 24-25 is difficult. We do know that 25-26, which we're starting to plan for now, will probably be just as bad. the change in government isn't likely to lead to a massive increase in the amount of resources that are available. We have got 2 significant events that are going to take place over the next 6 to 8 months, which will give us an indication of where we might head. The first is an autumn statement in hopefully a few weeks' time, which should give us 3-year numbers around capital. And then we've got the spring statement, which will take place in 2025, which will hopefully be a more formal, longer term looking spending review. And that'll look at the day-to-day spending, the revenue spending in a bit more detail and give us some clear ideas of what the government's intentions are. I think the important thing to say at the moment is everybody's downplaying the likelihood of additional resources. It's important that we do the right sort of things to keep our house in order and take advantage of any opportunities that arise over the forthcoming few years. There are a couple of things I'd just like to thank the finance and other staff for over the year. We've onboarded a new internal audit provider, and they've slotted in and are starting to be really effective in helping us to improve as an organisation. We've just retendered for our external audit providers, so as of next year we'll have potentially a different external audit provider for the trust, and again that'll require some effort and activity to onboard them if it is a new provider. We've got been given particular roles around ensuring that some of the new initiatives and some of the new capital initiatives can take place in the right way and not overly harm the rest of the trust or the system's finances. So it's required us taking specialist advice about how we can make some of those happen and work actively with partners to be able to deliver them in the best way possible. And then finally, a bit of a techie piece of work that took place in the finance team, but actually helped really well in delivering our position for 23-24 was around revaluation of leases. It's not terribly sexy or interesting, but actually did deliver a big benefit to the organisation and has helped to keep us in the good position we're in at the moment. So big thank you to all the staff involved in that and everything else that we've taken place during the year. Thank you very much, Tracy.
Thanks, Pete. I think we're handing over to Lynn Walshaw, our lead governor. Lynn.
Thank you, Tracy. Good afternoon, everybody. I'm Lynn Walshaw. I'm lead governor for DCHS. If we can put the first slide up, please. Thank you. I thought it would be helpful just to give a little bit of background of what we are as a Council of Governors and what we do. Again, sort of just to give a fairly brief overview, we are made up of 18 public governors. They come from a broad walk of life, lots and lots of different experiences and different thoughts and ideas that come to the table through that opportunity of being a governor. We have 10 staff governors. Again, they cover both non-clinical and clinical roles across the organisation. And we have 3 appointed governors, and they come from some of the partners that the Trust actually work with quite closely. So we have representation from local authority, from the voluntary sector and from the University of Derby. As governors, we cover 3 constituencies. So we cover Derbyshire, we cover Derby City, and a constituency that is actually classed as the rest of England. And as I said earlier, we have 2 staff constituencies, clinical and non-clinical. Essentially, what we're here to do is we work on behalf of local communities to represent their views and their feedback both into and out of the organisation. We work really closely with Julie as the chair, with our non-executive directors and with the board, looking at the performance monitoring of the Trust against its known priorities. Again, we have a range of meetings. I'm going to go through a little bit of those on the next slide. But again, sort of part of our remit is really around participating in the appointments of the Trust chair and some of our non-executive directors. So I'm going to move on to the next slide, please. And this is just going to give a reflection, really, of the past year. You know, we've heard some really, really good examples already today of some of the work that goes on across the organisation. And I just want to reflect, really, as a Council of Governors, what we see. We are essentially looking for assurances across the organisation. So we enact that through meeting as a council, and we meet on a regular basis. We've met 6 times plus an extraordinary meeting. We hold our governor elections to ensure that we've got a robust Council of Governors in place constantly, and that's both public governors and staff governors. But the bit I want to really reflect on is what we participate in and what we see across the organisation. And I'm going to do some of this sort of more globally. I'm not going to walk you through every single item on the infographic. It's just to give a sense of what we actually see. So things like the Quality Always, gold panels, plus dignity panels. Again, it is an amazing way of actually seeing the innovation, the creativity, the enthusiasm and commitment that teams actually come to that panel with, all of which is about striving to make patient care the best experience it can be. And I and my governor colleagues are constantly amazed at the ingenuity, I think, that is shown through some of these panels. And, it's very humbling at times to actually see the work that's being done. Again, similarly, in-site visits, people have mentioned earlier, a really good opportunity as governors to be out there, to talk to the teams, to actually get that sense of what is their lived experience of actually working within the trust, what is it that's working well, what would they like to see change, and what help do they need. It's a really, really good way of actually measuring, I think, sort of, what is happening for patients out there. It's the constant improvement pathway is what comes through. One of the statutory requirements that we undertake as governors is the patient-led assessments. Again, a national initiative, and that is looking at the assessment of all of the inpatient areas. And again, it's always a breath of fresh air to go out there, to talk to patients, to talk to carers, see the environment, get a sense from them what it actually feels like to be cared for within DCHS. And it's always a really uplifting sort of assessment. Everybody is always really, appreciative of the fact that there's a local provision and that the quality of care is of a really high standard. We're also involved in the complaints review panels. Again, as people have mentioned earlier, that's always a really interesting sort of review panel to look at, why people have complained, where services haven't met expectations, how that's been managed, and what the learning is from that. There's always a really honest, healthy debate, and the fact that there is always learning taken from that is then shared with teams, again, I think from a council's perspective is a good way of looking at the levels of assurance. Again, one of the wider committees that we work on is the Public Participation Committee, which is a system-wide group, and that is really focusing on engagement, on insight, what is that lived experience from service users, how does that actually reflect back into organisations, and how does that influence strategic development going forward. So it is that way of actually ensuring that constituents, citizens' voices are clearly heard, and that there is feedback that comes through some of that. We have a really healthy relationship with chair, with the board, with our non-executive directors. There's that mutual respect, as people have mentioned earlier, where we can actively and openly and honestly challenge each other, ask each other questions, and I think that's a really healthy place to be, that everybody collectively is seeking out the best level of quality care that can be provided within the constraints. Like any NHS provider, it's been a completely and utterly, challenge, I think, to get through this past year. Lots and lots happening at national level, at local level. Having said that, looking into DCHS, which is what we do as governors, we see that constant strive to actually maintain quality or improve quality. And I think from an assurance point of view, we see that through every sort of level of contact, whether that's working with, the executive board, the non-execs, actually seeing staff, talking to patients, being out there and talking to constituents. So, I have every confidence as lead governor, and I'm sure my governor colleagues will say the same, that, DCHS is doing its utmost to provide a real high level of quality, sustainable care. I think, recently we've seen lots of headlines where, we see, the NHS is broken. My reflection when I first saw that one was perhaps people and my, political colleagues need to step into DCHS for a year and see that this is a good way it can recover. And it could be on a real quick road to being mended. Seeing what we actually see on a day-to-day basis is a phenomenal example of, high quality care. And, what I'd like to end on is to say a huge thank you, as a public member, on behalf of the public, thank you for everything that gets done within DCHS. I would certainly be happy to be a patient. Yeah, thank you.
Thank you, Lynn, and thank you to everybody that has taken part in the last part of the meeting. And we're going to hand over now to Jim Austin, Incoming Chief Executive, to talk about the year ahead, or the year we're in, I guess.
Thanks, Julie. Good afternoon, everyone. It's been an amazing 2 hours that I've been listening really carefully to all the presentations, and thank you everyone for the contribution. It's been amazing. Today I'm the Chief Information and Transformation Officer for the Trust. On Monday I'll be picking up the Chief Executive role. And Tracy talked about the 13 years that she's been Chief Executive and this Trust has existed. I've been working with her and for her for the last 9 of them. And, I haven't said this publicly anywhere yet. It has been a complete honour to work with Tracy. She and I share some very different views, but share a very similar value set that allows us to challenge each other very hard. And I see that across our exec team and within our board as well. We have the same value set and different opinions, and that allows us to get better solutions. And I see that coming through in all the presentations that we've seen over the last 2 hours. I've only got 3 very quick slides, and actually Darren and Michelle and Pete have all covered a little bit of a look forward into where we are now halfway through this year. And I thought I'd just quickly talk about the integrated care strategy. I'm going to do a little bit about how that fits together with the strategy and plan for the Derbyshire system. But I want to just spend a couple of minutes before I get into that, just talking about the Lord Darcy report that came out earlier today. It's 163 pages long, and I got up early to read it this morning and shared some of my thoughts with it. And there's lots of thoughts and opinions in the news coming through. And if you haven't seen the headlines, it's the #1 leading article on the BBC. And it talks about, and Wes Streeting, the Secretary of State for Health and Social Care, and Keir Starmer, the Prime Minister, have both commented on it publicly this morning. 3 big shifts that we as a nation will need to undertake to ensure that, and Lynn, you referred to it, the broken NHS is not beaten. So broken but not beaten is the phrase that they're using. And I definitely see that within DCHS, we are definitely not beaten. In fact, I'm inspired, and I think there is huge hope for us if we can learn from some of the things that our teams are adopting and adapting and improving. So the 3 big shifts are from hospital to community. And we are clearly one of the largest community providers in the NHS in England. That should give us absolute inspiration and hope. And Michelle talked about, and we saw some examples in the first half of the meeting, about some of the ways that we are providing integrated care for people in their homes, out of hospitals, across the sectors, working with local authorities and across providers with the voluntary sector in a way that is quite forward-looking. And it's a model of care that we want to reinforce, and I think the government will want to come and look at and copy and help us with. So from hospital to community. The next one is around analog to digital, and we're in a very good space for that as a trust. We have a great deal of digital capability. There is work to be done, I'm sure of that, and we have got some of the investment profiles and capabilities to do that as well. And then the final part is around treating sickness. It's around it's preventing sickness rather than treating it. And when I think about the work that we've done around access, inequalities, and the work that we're trying to do around addressing deprivation and ensure that we are attending to areas of the population from a population health management perspective, again, I think we're leading the way. So we have huge hope. What the government and Lord Darcy have announced today is completely in line with the strategy and ambition that we have as a trust. And I think we should be taking great heart from that. And we should be saying thank you to all of those that helped develop that strategy and plan under Tracy's leadership. But there were hundreds of us involved in the creation of that work that has brought that together. So a thank you for that. So just 2 more minutes from me, and then Julie, I'll hand back to you for the questions bit and your summing up. But so integrated care strategy, the slide that's showing you now, alongside many of our partners, we're going to play a significant role in delivering that. The Darcy report helps us with that. The Derbyshire strategy talks about start well, stay well, age and die well, and we have a part to play in all of those elements, whether it's our children's services, 0 to 9 needs services in the start well, our stay well through our outpatient services that we run and our inpatient hospitals, and the age and die well, where we have a huge amount with the older population where we intervene and help. We've got some fantastic examples of our dementia end of life team who are doing some brilliant work and are nationally recognised for it. So the 5-year plan, the joint forward plan, was published last year and has been refreshed. We're absolutely part of that. Can I go on to the next slide, please, Dom? It's just clicking. Here we go. So we'll get there by prioritising prevention and early intervention. The Darcy report this morning helps with that. Now, clearly, these slides have not been written after the Darcy report. We've been preparing for this meeting for a long time. So this is about resonation around what is the government trying to do and where are we. Reducing inequality and outcomes I've talked about. Developing personalised care based on the strengths of peoples and their communities. When you think about the strategic aims that we've got, the 4 parts that we covered at the beginning of the meeting, wrapping our care and developing our services around our population and the individuals within it is going to be essential to doing that. And that is how we will start to achieve that. The work that Danny talked around our podiatry intervention draws out those examples where we're trying to fit the right intervention around the right patients and the right need to get a better outcome. And then finally, there's a bit around improving connectivity and alignment across Joint Up Care Derbyshire so that people experience joined up care and we create a sustainable health and care system. Some of that will be digital, some of that will be signposting. But if I think about Team Up, it's around clinicians and therapists, who are obviously clinicians, administrators, voluntary sector, all working together across boundaries, not worrying about a DCHS badge or an NHS badge and thinking about the citizen at the heart of what they're trying to attend to and working to get the best outcome for that. And I see that as an example that we're seeing today in our Team Up teams. And then finally, if you move on to the last slide, please, for me. So I've mentioned this, our strategy supports that. We have fantastic ambitions. It's definitely worth looking online. Get onto the DCHS website. You'll see it under as the published link in there. We are here to support our patients, community, staff and partners. We used to talk about the quadruple aim a lot. That's still fundamental in what we're doing. Quadruple aim is around improving the experience of care. It's around improving the outcomes of care. It's around improving the experience of the caregiver. And it's around ensuring that we can reduce per capita costs so we can do it for the best value of money. And actually, when you think about the Darcy report and what we've talked about today, we're trying to achieve all those 4 things together, because you can't just do one and ignore the other 3. We have to do them all together. And I think what the government report, the Darcy report today has indicated is that as an NHS, we may not have been allocated the funding we might want. We may not have spent it in the right way, but we've probably focused on some of those elements of the quadruple aim over and above other parts. And I'm really confident in my 9 years at DCHS, and I'm going to come back to Tracy at the end of this, and the 13 years of leadership, we have been, as an organisation, completely focused on doing the very best thing for our citizens that we support and supporting the staff who deliver it to be able to give of their best. And fundamentally, if we can do at least those 2 things, the other things will follow. So that was it. I think there's a lot of hope here, Julie. I think there's a huge amount of hope. Broken but not beaten, I'll take. I was furious when he said it was broken, 5 weeks ago. I'm up for the fight, and I'm very confident that we have 4,500 colleagues in the organisation who are absolutely up for it as well. That was it, Julie. Over to you. Thank you.
Thanks very much, Jim, and thank you very much for that optimism. I certainly, as chair, and I know the rest of the board and the rest of the organisation are going to really look forward to your leadership as Tracy hands over to you. So that's great that you are so optimistic. Can we just now, before I go into concluding remarks, just ask for any questions from the audience? Questions, observations, reflections, anything from you this afternoon?
Can I just say thank you for this meeting. I've enjoyed it. It's been full of really exciting information. I've heard nothing at all, and perhaps it's not surprising, but I think it is important, about an obesity strategy and what the trust standing is on that particular point.
Thank you very much. I can't quite see who said that, but thank you very much for those comments. Tracy, do you want to respond to that?
Yes, I can have a go, and then other people from the exec team chip in. So obesity it was about obesity. Was that right, Kenneth?
It is.
Yeah,
absolutely.
Obesity is a hugely important issue, and I haven't read the whole Darcy report yet, but Jim, I bet it's picked up in there as one of the drivers of ill health that we all need to get together and do something about. As part of the Stay Well element of the integrated care strategy, we are, with system partners, working on the development of an obesity strategy. And in fact, one of our executive directors, Jane Needham, she's on holiday in Canada, otherwise she'd been here answering this question, is leading on that work. So working with the 2 local authorities, directors of public health, working with general practice, working with the voluntary sector and with the integrated commissioning board, care board. But that is going to take some time. So I think it's fair to say as an organisation are a little bit frustrated. As Jim has probably alluded to, that we know the more organised we could get to have a really good obesity prevention strategy and support people who have got weight management issues in our communities, the bigger difference we'd be able to make to their health going forward, and the more sustainable we'd be able to make the NHS, because we'd avoid them having health problems that will become much more difficult and much more expensive for the NHS to manage in the future. Today's pressures mean that resources have not flown in that direction to the extent that we would have liked them to. Lord Darcy's report, I think, is signalling something very different, and the 10-year plan that the Prime Minister has trailed is a health plan for Britain as opposed to a plan for the NHS. So I expect the system to get a great big boot up the backside, actually, Kenneth, to get on with turning our ambitions around supporting people to prevent and manage obesity turned into action. In the meantime, we provide a specialist weight management service, and as I alluded to in my review of 23-24, we are very, very severely constrained. We've seen an enormous increase in the number of referrals into that service, and we are struggling to manage that demand. We require a joined up strategy across the system and a relatively modest shift of investment and resources into that front end prevention. We're tackling smoking cessation, and obesity is the second priority for the system.
Thank you for that. Thank you.
Thank you very much, Kenneth, and Tracy for responding. Any other questions? If you could raise a digital hand, I'll make sure that you're brought in. No other questions at this point. Okay, well, I'll move us into the concluding part of this afternoon. I hope you agree that we've heard about our overall performance in 23-24, and we've had just a snapshot of some of the things, the excellent initiatives that we're proud of. And we've also been honest about the areas where we need urgent attention, whether that be in terms of waiting list, service provision, experience, and to support our staff. I just want to say a very big thank you to the Chief Executive's Department and the comms team for organising the event, all colleagues who have contributed today, and particularly our BSL interpreters. Thank you. I'm in awe of the way in which you are able to provide accessibility for those hard of hearing. And a big thank you to Dom, who has helped the afternoon flow, and all colleagues for the utmost that they do with our patients every single day. and all present for your attendance and contribution. And so I said I'd come back to Tracy Allen, who I actually want to have the last words today. And so she will appropriately close today's meeting. I'm sure you'll agree with me wholeheartedly that we've been lucky to have Tracy at the helm for the last 13 years at DCHS. She's one of the longest serving chief executives in the NHS, which says a lot about her stamina and her commitment, which we know to DCHS, but to Derbyshire and colleagues within the Derbyshire system. Tracy is a mentor, a friend, and an inspiration to many of us. Her leadership style is characterised by humility, empathy, and a genuine concern for the well-being of everyone at DCHS. And the culture she's created will leave an indelible impression on the organisation. And we will hope to follow and leave you and carry on with your legacy, Tracy. She's been relentless in her ambition to improve services and patient experience for local people, and has been instrumental through her style to greatly enhance relationships with our many partners. She guided the organisation to Foundation Trust and onto an outstanding CQC rating, and has led us through many ups and downs with her wisdom and her dedication to the role. She's also routinely earned a spot in the Health Service Journal's top NHS chief exec, which I know she is very humble about. And she's been hugely influential in establishing a place within Derbyshire. Tracy said to me earlier in the year that her ambition was to be recognised as a competent leader who cares. And she does that in absolute buckets. From the bottom of our hearts, Tracy, thank you and good luck in all you do. I'm going to leave you with the last words because I have to.
Thank you. Yeah, it has honestly been a real privilege to play the part that I have played in DCHS's establishment and development. I've given it my all, and I've been able to do that for as long as I have because I am inspired every day by just fantastic people right across the organisation doing amazing things. And as I've said before, I'm proud of what we've achieved. I'm equally proud of how we've achieved it. And I think there's always things that can still improve and things that are not good enough within any organisation as complex and as large as this one. But we together have really created something very special in terms of DCHS, and the relationships that the organisation has, the way in which our services are embedded right across Derby and Derbyshire, I think are a credit to everybody. And they, as Jim has said, leave DCHS in a really fantastic position to capitalise on the new plan for the NHS. And I leave this organisation resolutely hopeful and optimistic, like Jim, that the money really will follow this time. And I can't think of a better group of people to make use of that money and that real focus on integrated neighbourhood, community-based services that are really about getting alongside people and helping them to live the life that they want to live in the very best mental and physical health that they can. And because I'm sticking around in Derbyshire and I'm getting on a bit, that's really important to me too. So thanks everybody for the ride. It has largely been a blast. It's certainly been a real privilege.
Thank you, Tracy. Thank you to everybody this afternoon, and have a good rest of the day. Take care.